Good morning, Doc Scenario. Ready for today's session?
Good morning, Dr. Tony. Absolutely, I'm eager to continue our discussion on alcohol-related disorders, especially alcohol withdrawal syndrome. I've been reviewing the signs and treatment approaches.
Great! Let's dive into alcohol withdrawal syndrome. As you know, it includes a range of symptoms that develop after either partial or complete withdrawal from alcohol. These symptoms can vary in severity, from minor signs to more serious complications like delirium tremens. Do you recall what the key stages are?
Yes, I do. Alcohol withdrawal syndrome is typically classified into 4 categories: minor, major, with seizures, and delirium tremens. Minor withdrawal signs occur within 6 to 48 hours after the last drink and include nausea, vomiting, tremors, and anxiety. Major symptoms appear 24 to 72 hours after the last drink, including tremors, heart palpitations, and hallucinations. Seizures can occur 6 to 72 hours after alcohol cessation, and delirium tremens, which is the most severe form, happens within 2 to 4 days, leading to clouding of consciousness, hallucinations, and even acts of violence.
Exactly. You've nailed it. The severity can differ depending on how dependent the individual is on alcohol. Minor withdrawal symptoms are usually self-limiting, but the major symptoms can be quite distressing and dangerous. It's crucial we monitor these patients carefully. Let's talk about delirium tremens. It's a medical emergency. What do you know about it?
Delirium tremens is the most severe form of alcohol withdrawal syndrome. It occurs in about 5% of patients within 2 to 4 days of significant alcohol cessation. The signs include confusion, disorientation, fever, and vivid hallucinations, particularly visual and tactile hallucinations. Patients might feel like insects are crawling over them. It's a short-term condition, but it can be fatal if not treated promptly.
Exactly. Delirium tremens is indeed a medical emergency that requires immediate treatment in a healthcare facility. It can lead to irreversible complications if left untreated. Now, what investigations would you consider to confirm alcohol withdrawal and rule out other conditions?
I'd start with a full blood count, drug of abuse screening, liver function tests, kidney function tests, and electrolytes. Additionally, a chest X-ray could be useful to check for any possible infections, especially since these patients might be dehydrated and prone to complications.
Right on track. Now, when it comes to treatment, you know that we aim to alleviate withdrawal symptoms and prevent serious complications like seizures and delirium tremens. Have you come across any pharmacological approaches for managing alcohol withdrawal?
Yes, I've read that benzodiazepines are the go-to drugs for detoxification. They help manage symptoms of anxiety and agitation while preventing seizures. We can use lorazepam, diazepam, or chlordiazepoxide in a reducing regimen. Lorazepam. Day 1, 1 mg every 6 hours. Day 2, 1 mg every 6 hours, except 12, 0.5 mg. Day 3, 1 mg every 6 hours, except 12 o'clock and 14, 0.5 mg. Day 4, 1 mg every 6 hours, except 12 o'clock and 14, 0.5 mg. Day 5, 0.5 mg every 6 hours. Day 6, 0.5 mg every 6 hours. Day 7, 0.5 mg every 6 hours, morning and evening doses. Diazepam. Day 1, 20 mg every 6 hours. Day 2, 20 mg every 6 hours, except 12, 1 mg. Day 3, 10 mg every 6 hours. Day 4, 10 mg every 6 hours, except 12 o'clock and 22, 5 mg. Day 5, 5 mg every 6 hours. Day 6, 5 mg every 6 hours. Day 7, discontinue or maintain 5 mg based on clinical response. Chlordiazepoxide. Day 1, 30 mg every 6 hours. Day 2, 30 mg every 6 hours, except 12, 2 mg. Day 3, 20 mg every 6 hours. Day 4, 15 mg every 6 hours. Day 5, 10 mg every 6 hours. Day 6, 5 mg every 6 hours. Day 7, 5 mg every 6 hours, morning and evening doses.
Good recall. The use of benzodiazepines in a gradual tapering regimen is crucial for minimizing withdrawal symptoms. But we also need to manage hydration, electrolyte imbalances, and potential infections. Don't forget about thiamine supplementation as well. Do you recall the SHAVERS acronym for managing these patients?
Yes, it stands for S. Sedation, using benzodiazepines for detoxification, H. Hydration, oral or IV fluids, depending on the severity. A. Assess for infections, treat appropriately, V. Vitamins, thiamine to prevent Werner-Korsakoff syndrome, A. Electrolytes correct any imbalances, R. Rehabilitation and reorientation psychosocial and physical therapies, S. Support, psychological support and counseling.
That's perfect. Doc scenario. Remember, thiamine is essential, especially to prevent Werner-Korsakoff syndrome, which is a serious complication if left untreated. I also want to emphasize the importance of continuous monitoring. In severe cases, the patient must be under close supervision, preferably in a hospital setting.
Got it. And what about the management of alcohol-induced psychosis or seizures? How would you approach these cases?
For alcohol-induced psychosis, we would differentiate it from withdrawal symptoms first. Patients may present with hallucinations, disorganized thoughts, and confusion that are not part of withdrawal syndrome. Antipsychotics may be necessary, but they should be used cautiously because alcohol reduces the seizure threshold. Low doses of antipsychotics are preferred. As for alcohol-induced seizures, we would manage them with benzodiazepines to abort the seizure. Afterward, we would focus on treating withdrawal symptoms, as the seizures might be a result of alcohol cessation.
So, for both conditions, we need to ensure that we are cautious with medication, especially regarding seizures, and provide comprehensive care for both the psychiatric and physical aspects.
Exactly. Doc scenario. Alcohol-related disorders can be complex, but with careful management and timely intervention, we can help these patients recover and avoid long-term complications. Keep in mind that rehabilitation and psychosocial support are key for preventing relapse after detoxification.
Thanks, Dr. Tony. I feel much more confident in managing alcohol withdrawal now. I'll make sure to incorporate the SHAVERS approach in my clinical practice.
I'm glad to hear that. Keep reviewing the key concepts, and don't hesitate to ask if you need clarification on anything. You're doing great, Doc Scenario.